Hello, practical nursing students. My name is Darlene LaPresto, and I'm a Jackson College nursing instructor, and today we are going to work on your skill, tube feedings. Okay, so I have my tray here of goodies. I just wanted to kind of walk through and tell you what we have. We have a graduated cylinder. We have a pair of gloves. We have a measuring tape. We have our pH strips to measure our gastric pH with. So I already have one ready in a little medicine cup. We have our piston syringe, which I have open and ready. It does not have to be sterile. This is what it looks like. We have an emesis basin just in case we need it, some tape, some prep for the patient's nose in case the tape is coming off his nose. We could prep the nose and then replace the tape. We have our ordered tube feeding. You want to make sure you go back and double check the physician's orders to make sure you're giving the correct type of formula, because we know there's many different types of formulas. We have our marker just in case we have to mark our tube for measurement, and then we have an extra blue pad. Okay, so we're going to get ready to start. Knock, knock, knock. Hello, Mr. Jones. My name is Darlene LaPresto. I'm a nursing instructor at Jackson College. I'm here to check your NG tube and give you your feeding today. Is there anything that I can do for you? Anything you need before we do this procedure? No? Are you having any pain on a scale of 0 to 10, 10 being the worst possible pain and 0 being no pain? About a 2? Okay. All right. And do you have to go to the bathroom before we start? No? All right. What I'm going to do, Mr. Jones, is put you up higher a little bit here so I can reach you, but I'll leave the side rails up. All right. So I'm just going to place a blue pad, just so we don't run into any problems maybe with soiling our clean sheets that we just did today. And this is called a Salem Sump NG tube. Some are bigger and some are smaller, but Mr. Jones had this placed about 2 days ago. It's held in place with tape on his nose, so we have to be careful that that does stay firmly attached, because that's what's holding it in place, and they do tend to come out if we don't really make sure that's secure. Now he has a black line at the tip of his nose, and that's where we're going to measure from. So after I've identified him, I've checked his name and date of birth on his armband to make sure I have the correct patient, because I am going to do a procedure on him. I'm going to go ahead and measure the tube that's sticking out, because we want to make sure that that has not migrated out or in. Now the policy at this facility is to measure, and we're going to do it in inches because that's what was measured before on the chart. We're going to measure from the tip of his nose where it is external, and we're going to measure down to where this last black hash mark is, if you can see that on the tape. And those are radio opaque, so when the patient goes down for a chest x-ray, that's how the radiologist can tell. So he's measuring at 20 inches external, and I've looked at the chart, and the chart confirms that he has 20 inches external, so I would want to document that. So I know that the tube is in place. Now another thing that I can do, some places, some facilities are not following this procedure anymore. It's called insufflation, and what we do is we're going to inject a little bit of air into the tube, and we're going to listen to his belly, and you should be able to hear some gurgling. So I'm going to get my piston syringe and just draw back with a little bit of air. And I'm going to listen with my stethoscope. Left upper quadrant, because that's where the tummy is. Okay, and I heard some gurgling. So that's a second way to confirm, but again, some facilities do not use that technique, so you want to make sure before you do that it's in your policies. The last thing that we need to do is we're going to check the pH of the gastric contents. Gastric contents have a pH of between 1 and 4. So by checking the gastric contents, we would know if the patient had the tube properly placed in the stomach, or if it's misplaced, it could be in the respiratory tract, which has a pH of 7. So I'm just going to remove just a little bit, less than 10 mLs. And you always want to put the plug back in, just because it might seep a little bit. And we're going to put it right on the strip. Okay, and we give it a couple minutes to read. And then compare it with your graph, and it's measuring at a 3. And we know gastric contents is between 1 and 4. So that confirms 3 different ways that I do believe that the tube is still placed within the stomach. Now we're going to check residual. Residual you check when a patient is getting feedings continuously, and you want to make sure that the body is absorbing all of the nutrients and it's not just sitting in the belly. Because sometimes we give the medicine, or the tube feedings too fast or too slow. So we want to make sure the patient's able to absorb them. So we're just going to pull back. How you doing, Mr. Jones? Okay, I've gotten a residual of about 45 mLs. And that's less than 100, so that's good. So I'm not concerned about him not absorbing the tube feeding. So I'm going to go ahead and put that right back in. And then I'm going to document how much his residual was. Now we put it back in because we're replacing the electrolytes. If we don't put it back in, the gastric contents, and we just keep checking residual, and pulling it out, then we're going to change his potassium, his sodium, all his different electrolytes, and we don't want that to happen. Now lastly, we're going to go ahead and irrigate, and we're going to give him some tube feeding. He has an order for a bolus of Oscal 1.5, and I have Oscal 1.5. The lid is clean. The expiration date is not until 2020, so that is good. We like to shake things around here. Now I have some saline already in my graduated cylinder, and I'm going to pull up about 100, and the physician will write specific orders on how much that he wants you to flush with. Remember, the plunger is, we want to try to keep it sterile. I mean, tube feedings aren't sterile procedures, but still you want to keep it clean. We're going to connect that firmly, and just easy gradual pressure. And we're just watching the flow up the tube. Okay. Now we're going to go ahead and give our bolus. So I'm going to wipe the top of this can off. I'm going to open it so it's all ready to go. I'm going to take this plunger out very carefully so we don't have any splashes. Maybe. Reconnect. And we're just going to allow this to pour in, and by gravity it's going to infuse into the patient. So just very slowly we would pour that in, allowing it to infuse into the patient, again by gravity. Making sure he's doing okay, he's not getting nauseated. Okay, he took the whole can, which is good, and we're going to be sure that we document that. And then one more flush. You don't want to leave any of that tubing filled with, the empty tube filled with formula, because it could clog up. So we want to do one more flush with our saline. Go ahead and flush it, and then when we're all done, we're going to secure it to his gown so that it's not pulling on his nose. So I'm going to get a piece of tape. And sometimes you'll see tape with a safety pin. We just don't want to puncture the tube. But we just don't want that pulling on the nose so that he can kind of move around in bed comfortably. So now it's secure here, it's secure here. If it were to be put back to suction or anything else, we would do that, but not at this time because we're giving a feeding. Okay, hand hygiene. Take care of all of your supplies. Make your patient comfortable. Assess to see if he has any needs, any pain, or if he has to go to the bathroom. And then be sure you do your exit procedure and let him know when you're going to come back.